Okay. Good morning. We're going to get started. We have our in-person audience here, and we also have our letting our Zoom audience in. Welcome to our department OBGYN Grand Rounds. I'm Tishani Alangasekra. I'm the director of our Grand Rounds program. And we're excited to have you all here today for this great talk. I just wanted to start, as we always do, with our land acknowledgement. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support. And we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And if you want to learn more about the Ramaytush Ohlone people and how you can contribute and learn more, we have some resources here that'll go into the Zoom chat as well. And so without further ado, I'm really pleased to introduce Dr. Karen Meckstroth. Dr. Meckstroth came to UCSF for Family Planning Fellowship in 1999 after residency at USC LA County and medical school at University of Chicago. And after fellowship, she founded and for over 20 years has been the medical director of the UCSF Center for Pregnancy Options, which is the primary service for abortion and miscarriage care at UCSF. This role sparked her passion for improving pain with uterine procedures, and she has published dozens of articles in the areas of family planning and also is a generalist OBGYN at San Francisco General Hospital, where she focuses on other underserved areas of gynecology, chronic pelvic pain, and menopause and management. She strongly values patient-centered care and focus on patients' priorities. And I think there's no better time for us to have this discussion and topic about improving pain in office procedures. It's out there. Our patients are talking about. It's on TikTok. It's on Instagram. And these are, I think, the things that we all should be doing. And so I'm really pleased to introduce Dr. Meckstroth.
Thank you, Tushani. My disclosures, which are not relevant to today's talk, and objectives for me and for what I hope to do is, one, to remind us that pain control is worth prioritizing. I don't think I have to convince anyone that that's true, but I think all of us are subject to a lot of time pressure in a busy clinic where it comes down to a balance, and that we're immersed in the really strong social norms that pain for people with a uterus is normal. Summarize evidence for pain management and uterine procedures, and help us provide person-centered care through global pain principles. So to really increase our toolbox and let us be flexible and meet patient needs. And then the second half is really to expand knowledge and options and your confidence for using local anesthesia, and really respond to the arguments I hear all the time about why people don't want to use it for uterine procedures or spend as much time doing it, which doesn't work, it takes too long, it hurts, or it has too many risks, or I'm scared. So this is putting a lot of different studies together, and they are not always with the same interventions. As you can guess, most uterine aspiration studies include local block. Many of EMB and IUD insertion do not. But the median, or some of few cases mean pain, and these studies kind of extrapolated to a 10-point scale, really show us that we need to do better. We have, when you look at severe pain, almost half of people with uterine aspiration experience what they would call severe, like 7 out of 10 pain. EMB also, half describe it as moderately as severely painful. And about 42%, at least in one study, and it varies, as I'm sure you know, mark their pain for IUD insertion as unacceptable. These two studies kind of span my time as faculty at UCSF, and it became really clear a long time ago, to some people later than others, that the the treatment of pain is subject to bias, and multiple studies document the undertreatment of pain for people of color and women and other groups whose pain is not taken seriously by healthcare providers. Sadly, even 20 years later, we're still seeing reviews that, and we know from our experience that there are significant disparities in pain management. And even a more recent study just a couple of years ago found that for uterine aspiration, white race and genetic anomaly were associated with people being given more pain medication. This was a study in Maryland, but lest we think that we are immune or different here at UCSF, I am cleared to tell you that there is a really great study coming up by Jackie Roger that Sarah Whetstone and I are helping with, that looks at IUD insertions at UCSF only, and found that we use block less often in certain populations and in other situations that benefit the provider. And as Tushani mentioned, there's been a huge, since 2022, a big uproar of social media advocacy for pain, specifically with IUDs, that has really expanded to other gyne procedures. I'm not on TikTok, but my two daughters are, and they started sending me these really early on. And then the mainstream media also picked it up. And now we have quite a lot of more of attention on it. And so all of this kind of tells us we often do pretty poorly with uterine pain control, that patients are often unhappy or in pain, and that this affects their future care and their friends' future care and what they see. And I just reviewed another study of what people see on the internet actually is dramatically negative about uterine procedures. And it's a well-documented disparity issue. So we have had about 30 years of research specifically about IUD pain, for instance, and reviews from just a couple months ago still saying effective evidence-based interventions for pain are lacking. And it is true that we are missing a lot of information and we could use a lot more, but we have a lot of evidence and we have a lot that we can build on and that we can use and make a difference for. And it does seem encouraging that the medical community is responding to this patient advocacy, which I really think is responsible for this change. This is just from my search of like what new things have come up in the last year since I've done this similar talk, and huge spike of articles for pain with IUD just in 2024. Unfortunately, there are still some people who are not convinced specifically for IUD and block. And I think the fact that up to date is not really supportive affects a lot of what people do. I mean, obviously, if you tell your patients, well, it doesn't work that well, it really only works in the cervix, and it takes longer, and it hurts to do it. Do you want one? You know, the chance that they're going to say that they want a block for IUDs is pretty small. I'm stuck. Let's try something else here. There we go. And you may have noticed in August, there was kind of a big hoopla when the CDC said, we made a really big change in our recommendation for IUD pain and that we think you should pay attention to it, but it's a pretty wimpy recommendation. Yeah, might be useful, but either way, it came up as a really big deal that at least they're acknowledging that we should pay attention to pain with IUD insertion. And in 2023, our division at San Francisco General, we had some issues in our clinic with concerns about equity in provision of block for IUDs. And I proposed that we have an agreement that it be at least an offer, if not a recommendation, for all of our patients in our 5N clinic. And at that faculty meeting, Rebecca Jackson said, I don't offer, you don't offer, it should be recommend. I was too chicken to recommend that to our faculty, but it was a unanimous support amongst our division. So we have had a guideline that everyone for EMB, unless you're doing it without a tenaculum, and IUD insertion, we recommend block. And the reasons, we had a long discussion about offer versus recommend, and there's some big differences. And one reason is that time can be a big barrier for, especially for our NPs, reported that in clinic. offer leaves room for bias to be inconsistent in how we present it. And even in multips where there's only 1 out of 10 severe pain, is that acceptable when we can do a very simple intervention? So we definitely also talk about alternatives for shared decision-making, but we start with that recommendation. And the evidence, there's quite a few studies that really support that, but these were kind of the 2 seminal studies that looked at block 10 cc's or 20 cc's, both one with a weight, one with buffering that we'll talk about it in a minute. That made a significant difference for pain with IUD insertion. Sorry. And just to remind us how hard pain studies are in uterine procedures, the same author who originally did a study for pain block with IUD in 2002 came out with the result of no significant difference. But the point estimate differences in that small study were a mean pain of 62 out of 100 to 24. I don't think anyone would say that that's not clinically significant. But when I was giving talks before 2017, people would be like, but the evidence says it's not worth it. So this distills down a whole lot of evidence, but putting it together, because I really think it's valuable to look, we are missing so much for all the procedures in the uterus that putting them together kind of also gives us more information and can draw from one to the other for other procedures. So as you can see, for aspiration, IUD insertion, and EMB, an NSAID is clearly been shown in all systematic reviews and guidelines to be helpful. Exactly how we do that or whether there's a difference, other data shows probably difference between NSAIDs is not that huge, but there are some IUD studies that suggest that tramadol might be better. And then a very recent Cochrane review also added Tylenol for aspiration. We've been giving Tylenol plus ibuprofen routinely to everyone at Center for Pregnancy Options for years. We do it for our ERAS protocols. It's low risk. They work in totally different ways. I find one of the most rewarding things about it is the 1-minute spiel I give to patients about ibuprofen is really better for uterine cramping for after, but your next second line that you can combine with it, it works for eliminated by a different organ, works in a totally different way. So it gives them a tool forever. So we do that routinely in Center for Pregnancy Options. I didn't include hysteroscopy partly because the most recent Cochrane was like, oh, 32 studies, we got nothing. But I mean, it's mainly because they looked at putting block in the distension media, which doesn't work, but we can assume that there are definitely studies that show the same 2 things for hysteroscopy. And most of the larger reviews also come out with the same conclusion. We need to study combinations of modalities. No one thing is going to be the answer for any group or for any one person, short of going to sleep. But that is a whole nother story that we're not talking about today. But I did want to mention that, yes, there is good data that moderate sedation helps with aspiration, and we certainly want to have it as an option for some people with EMB or IUD if they need it, and we do at both of our medical centers. So it made a significant drop to add a good dose moderate sedation compared to oral meds, but you'll notice that 1 out of every 6 or 7 people still had severe pain, even with moderate sedation. So I find that knowing that there's not one thing, stepping back and looking at pain from a little bit more of a global perspective and thinking about bigger principles helps us have more tools and helps us be more flexible when people need changes. So we know that pain is not nociception. Oh, where's my little thing? I lost my... Sorry. Well, I don't have that pointer anymore. So pain is not nociception. At the bottom, the sensory discriminatory, but it's affected by the mood at the time and what pain really is, which is the cognitive evaluative component, like how people feel that pain is in their life and what the significance of it is. And there's a lot we can't affect, but in the pink circle, you can see that there's a lot we can. There's a lot of modifiable risk factors that can make a difference. And of course, this is way over linear, but at least it shows the multi-layered factor of what we're thinking about when we're talking about pain. The other thing that I find really helpful is there's a load of psychological research that shows that the way people evaluate negative experiences is not like adding up how they felt at every moment and that gives you a score. It's kind of the peak end rule means they feel how they were at the worst moment and how they feel at the end is by far the majority of how they evaluate the experience. So that gives us also support that if we are able to make it better, I don't know anyone who thinks an extra 2 minutes with a speculum, if it's not causing pain, is going to be a good trade-off or would be a reasonable trade-off if it actually means that their pain would be better. But we do know that shorter procedures are great, but you have to look at that all together. And the speculum is just how we get to what we do. And we often kind of forget that can cause a lot of discomfort for people. About 17% of a general population found pretty significant pain just from a pelvic exam, 30% of people with sexual abuse. And you'll notice that in the factors in the multivariate analysis, when they go through, everything's odds ratio of about 2, except the negative emotional contact with the examiner. So that could be a bit of a chicken and an egg. I don't like you because you caused me pain, or you caused me pain, so I don't like you. But I take from that creating rapport is part of pain control. And we think about that at CPO, even like on phone calls, that when people feel like they trust and they recognize people and they have a relationship, it makes a difference. And kind of the extension of that we're all familiar with is trauma-informed care. And I would certainly, some people need a lot more attention to this than others, but many people don't want to disclose their trauma history. And pelvic exams are intrinsically a type of exam that would be difficult for many people. So I think that having at least a basic level for all comers for pelvic exams really makes sense. So patient in the control, having control, I think it's only been about 10 years in our division, probably department, because I think all the residents do it, that we have been saying, is it okay if I place a speculum now, rather than I'm going to place a speculum now? Those sentences take the same amount of time, and it's a big difference. Meeting the patient beforehand, asking about their preferences, concerns, or interests. You'd think that takes more time, but it helps you be targeted. It helps you give patients what matters to them. And then calm, respectful atmosphere and low stimulation. I can't say enough about going slowly. I hear that over and over from others as well, but the incredibly slow start to any pelvic exam where there's room for people to accommodate, to respond, to give you information is really worthwhile. And there's, you can get wind up from any little discomfort early on. And we only really think about pain in kind of the local block, the tenaculum, the insertion, for instance, for IUDs, and how people feel cramping afterwards. But if you've ever seen someone take a giant wad of cotton and jam it into the vagina, you can imagine that no one studies that. No one asks for a pain score for that. I've seen that be the most painful part of a procedure multiple times. So there are so many ways that we can be attentive to making a procedure comfortable. And when we talk about wind up, I found it really fascinating that they've actually studied this with functional MRI, that if we say words that are kind of associated with pain, it leads to higher pain experience. So in the moment, if you're saying words that might trigger or make someone think, oh, I'm feeling pain now, that increases their pain. And it's critical that we explain the possibility of pain and what can happen and and not try to hide that from patients, but avoiding words that are triggering in the moment has been clearly shown to make a difference. I found that the TEACH program, which trains family medicine to do uterine aspiration, they have a really wonderful list of like, here's a whole list of words to start with and think about how these might sound during a pelvic exam. I also made a guide for that for med students years ago that you might have seen around, but this one I just found a couple of days ago, and it just has tons of examples, and I thought it was great. So clear evidence that anticipated pain increases pain. And it's really challenging. How do we balance giving people accurate information, not someone put up a onion thing is the provider tells you that it will just be a little pinch and then you're unconscious on the floor. You know, I mean, we want to give people a accurate range of experiences without telling them what they're going to experience. We know that people, the way that they describe and feel pain is very different. How they feel sensations of a pelvic exam are very different. So we can't know. And it doesn't make it more right to tell them, to label it for them. One way that I found that this is to balance this is to say, I can't promise I won't cause pain, but I promise I will respond to any pain, and that my goal is not to cause pain. I really don't want to cause you pain during this procedure. So if you feel any pain at all, please let me know so I can adjust and I can make a difference. Now, for me to be able to say that, to say, I expect not to cause you pain, I have to believe it. I have to actually think I have the tools not to do that. And obviously, one of the tools is stopping, but there's also having a lot of minor tools that I can bring in or things that I can do ahead of time. And the big strategies, I know you've heard about both of these, that multimodal pain management is an absolute requirement for pain control, because there's not one thing that makes all the difference. So combining things together. And then preemptive, avoiding windup, avoiding the brain and nerve pathway that once people feel pain, they feel it more the next time, or they are faster to get those pathways activated. And so even though we have data about what groups of people have more pain during uterine procedures, this is mostly with aspiration, but a lot of this has also been found in other procedures as well. I don't find it's really helpful to make our decisions based on what group studies find about people. We don't know what an individual will feel, and a 35-year-old multip with an anteverted cervix and no dysmenorrhea can absolutely have severe pain with an EMB or an IUD insertion. And so I do find this helpful to look at the modifiable risk factors, what we can do, reduce anxiety, involve people in the choice of what we use, understanding of the procedure. There's a lot of evidence for that. And what I also take from that is I really feel like we should think about the fact that everyone can have pain. As I mentioned, like 1 out of 10 multips with IUD insertion, many people are like, oh, I only offer for nullips because that's what the evidence supports. But what is okay? What is it? At what level of severe pain should we not be treating them and giving them the same options? So the big question is, what are simple options we should offer to everybody? Should we, I mean, we can't offer everything. I definitely don't offer everything on this list, even when I'm doing a uterine aspiration. But I think most of us really believe that participation in decisions and preparation make a difference. But I know for me, I do that much better when I have more time. So there's a variability in how we do that. And then distraction a little bit, everything from talking to the patient if they're agreeable to that, or touching next to the speculum to distract at the time that you're starting to do a stimulation in the vagina, or tapping a knee. There's, I find that heat and aromatherapy, we use, you know, a little 2x2 with light, tangerine and lemongrass oil and CPO a lot. And we do that because when people get lidocaine side effects, it's a great diversion of attention. Maybe it's also aromatherapy, I don't know. But it's also providing something that demonstrates to the patient that you care about their pain, which I think is also valuable in itself. We have TENS, there's great evidence for TENS. I've never tried it. Music, there's also great evidence for that, although interestingly not for patients' chosen own music with 2 headphones. And that is possibly, or I mean, speculated, it's because it closes you off from communication. So you can't, talk to the provider about when you might feel something that is, this is just cotton in the vagina, or you might feel a little pressure now, or a little more movement, something that connects you. One thing that you might think should go in our multimodal routine option would be misoprostol for using uterine procedures. And there is a load of evidence that it should not. So the trade-off of pain and time for misoprostol for all the uterine procedures has been shown not to be helpful routinely. It doesn't mean we shouldn't consider it for other reasons, like doing an aspiration for a miscarriage where the tissue might be dense and we need those extra couple of millimeters, or if someone has fibroids and we might need to navigate a long pathway or something like that. But for routine use, there's clear evidence in all the procedures. So moving on to the next half of local anesthetic. One thing that I find I say all the time is, how are we the only specialty that expects local anesthetic not to work? You didn't see anybody else in other specialties to have a small area of tissue where they're going to use local anesthetic and be like, oh, well, it didn't really work, but that's okay. You know, we accept that if we do a block, and when I was just out of fellowship and starting pregnancy options, and I knew all the data about pain with aspiration, and I started a procedure after doing a block, and the partner, who was a dentist, looked at me and said, I would never do a block without testing it. And I started to open my mouth to say something about all the evidence that says that waiting doesn't help. And I was like, yeah, I cannot argue. There is no reasonable argument against that, yet it is so not routine in gynecology. They aim to block all the nerves they're going to bother, and they use as much as within the safety range. So I'm hoping I can help us do that more. And one thing is to know the neurobiology about local anesthetics, and how it works is important, that it actually works in multiple ways to prevent nerve depolarization. One of the more minor ways is probably separation of the nerve ending so that the neurotransmitters have to travel farther. We know that's not the primary mechanism, but it's one of them. And then with all the data about waiting or not waiting, it takes a couple minutes to work. There's no question that for the activity of the medication, it takes a couple minutes and sometimes longer. So autonomic and small A delta fibers are often numbed very quickly. We've all had the experience that you put 2 cc's in the anterior lip and people feel nothing with that tenaculum, even instantly. But if you are squeezing it, say Alice tip tenaculum, that is different. But other fibers take longer. They can take up to 10 minutes, 7 minutes. The nerves that we want to bother, that we are going to bother with uterine procedures, are the sympathetic nerves that come in through the infundibulopelvic ligaments and the uterovarian, and the hypogastric, the uterosacral ligaments that go up the back that innervate the fundus, and then mostly the lower uterine segment and the cervix are innervated by the Frankenhauser plexus that comes in laterally. But there are also sensory nerves everywhere and throughout the uterus, and connected in many ways. So how should we do a block? And say there is no evidence to tell us there is one way to do this, or that one way works better at all times. The best studied block in the top right is the 4-point block, and this is mostly for aspiration. Studies for EMB and IUD are a little bit more commonly using 2-point and only 10 cc sometimes. But I tried to create the fact that the vaginal epithelium is the striped part and the lateral cervix is the middle circle. The reason is because the vaginal epithelium has a lot of pinpoint nerve receptors. So if you put the needle, like it shows in that left side with the going in lateral to the cervix, there are pinpoint nerve receptors there that really detect a very big difference compared to being on the cervix. There are pinpoint nerve receptors on the cervix, but way, way fewer. So when we talk about paracervical block, it means so many different things. It could mean that people are going in the fornix into the vaginal epithelium, way off into that fluffy areolar tissue where it floats out into never never land. I mean, anyone who's done gyne surgery can look at the tissue lateral to the cervix and say, yeah, that's not where I want to put my block. And people often don't want to put it in the stroma because it's harder to inject. There's no question that sometimes it's harder to inject in the cervix, but that also slows you down, which might have an advantage. So we know that deep injections are more effective, but they hurt more. And one way to counter that is to really start giving medicine very superficially and then gradually until you get deeper. What I do is kind of a hybrid in that I do go in laterally on the side often, but you aim for the uterine stroma. So I would say the parts that I do think evidence supports is that you put it in the stroma, not the uterine tissue, and start your injection on the cervix and give the medicine superficially. So how much can we give? If we want to be able to add more, it's really helpful to know the onset maximum or that maximum dosing for the medications. Lidocaine is by far the most common that we use. And the package insert says 300 milligrams, which is 30 cc's of 1%. It also says 200 milligrams for pregnancy, although that is for a number of reasons. There's a fetus, because we used to give it in labor, and not based on any concern in early pregnancy. So even in a 120-pound patient, you've got to 25 without a vasoconstrictor. And if you add a vasoconstrictor, you've got 38 milliliters before you are there. I don't ever get that high. And one thing about lidocaine is that also, if someone's awake, they can get minor symptoms, which we'll talk about in a second. But bupivacaine is intrinsically vasoconstrictive. So you can see that the max dose is the same in the middle with a vasoconstrictor or not. And we still put vasoconstrictor in our bupivacaine or vasopressin in our bupivacaine, but it probably doesn't do much else because the bupivacaine itself is very vasoconstrictive, which is one reason it takes longer to work and it lasts a lot longer. We used to use chloroprocaine in San Francisco General and 6G. We switched that recently. But the reason was because if you could put a whole slug of it into the vascular system and it doesn't cause any problem, and we have a lot of learners there. But the downside is that it has like a 23-second half-life, probably longer if it's in dense tissue with a vasoconstrictor. But by the time you're done with your procedure, the effect is much, much less, if not gone. So vasopressin, we don't use this anywhere else other than CPO that I work for IUDs and EMBs, but it is something to think about. I think it's really important for uterine aspirations because it increases the safe amount that we can use, or office hysteroscopy, by a lot, and therefore it decreases the side effects people get, which aren't dangerous but annoying. It prolongs the effect. It makes it last a lot longer, decreases blood loss, only shown in the second trimester. And it decreases the force of dilation, at least in a hysteroscopy study. One thing that I really wish we didn't have in our 5M clinic is Lido with epi. I mean, okay, maybe if you want to use it for an implant removal, but other than that, we should not be using it in the cervix. One, it doesn't work. It's way too much vasoconstrictor for the amount of lidocaine we would use. It makes it take a lot longer to work. It's acidified, so it's painful to inject. I had a former faculty here who has moved on and called me a couple months ago and be like, hey, can I ask you about epi for cervical blocks and your lidocaine? Because I did it and it really didn't go well. I'm like, yes. So lidocaine toxicity, when someone gets those symptoms of tinnitus or perioral tingling, those happen at serum levels that are far below concerning levels where we're worried about seizures or cardiovascular symptoms. It doesn't mean we shouldn't take them seriously because they're uncomfortable. But if you'll notice, if they get that and you wait a minute, they often go away in like 60 seconds. There's only one study in all of gynecology that looked at 300 milligrams of lidocaine. And that study was an intrauterine lidocaine study, also trying to numb the fundus. But what I really think the study did was compare a low versus a high dose, because the total dose for lidocaine was much higher. And you'll notice that the drop in pain here was even more than with adding moderate sedation. So the difference of using a high dose of lidocaine could be a big difference. This is the only study we have, but we routinely bring in extra lidocaine, and it is not rare that I give an extra 10 cc's for uterine aspiration after having given 20. I've become more and more a fan of bicarb. We still also don't have this in a lot of our clinics, but there's data that it decreases pain with injection. Any dermatologist would never do lidocaine without buffering it. There's also, what I've learned more recently is that it makes the drug work better. More drug crosses the cell membrane in a normalized pH environment. So it increases the onset of action, makes it work better, and decreases pain with injection. 1 to 10 is the ratio that we aim for. And I'm not going to talk about all the issues with mixing things in clinic, but that is something that we want to be very attentive to. So I've gone through a whole lot of variables that change how local anesthetic work. Didn't even get to the temperature injection. We've never warmed our lidocaine. But depth, rate, there's evidence for a lot of these. This is where I come to the bottom line of testing. As I'm starting a procedure with either a tiny dilator or a sound, I ask people to let me know if you have any pain. Please let me know. You might feel pressure and movement, but any pain, let me know. Because if I can block cervical pain, the chance that it will help the fundal pain is going to be a lot better as well. There are data. I had a good debate with John Markley, who's anesthesia at the General at National Abortion Federation this weekend, about whether there's any pathway for drugs in the vagina and the cervix to be absorbed into the uterus. And lo and behold, we did find that there is evidence for both lidocaine and progesterone. One of the other more common reasons people say I don't want to do block is it can be the most painful part of the procedure. If you take a fat needle and inject really quickly, especially in the reflection of the fornix, absolutely, it could be the most painful part of the procedure. But there's a lot of ways we can make it barely noticeable. We talked about the distraction, labeling, buffered lidocaine. Small needle. I always start with a 25 or smaller. I have a colleague in Seattle who's like 25. I wouldn't use anything bigger than a 27 or a 30. I still have yet to try that. Starting superficial, like 1 or 2 millimeters, so that your medicine precedes your needle. Slow injection is very evidence-based. And if someone feels something, you can stop. You can add more block. I know people that just spray a little bit of lidocaine on the cervix. That may not work if it's highly dilute. But the clear intervention that makes a difference is topical lidocaine. There is good evidence for that. Topical lidocaine helps both with how the block feels, but there's also studies that it helps with uterine procedures. So higher dose topical lidocaine. So EMLA cream or 10% lidocaine, which we don't have in the US, although I did once talk to our pharmacy about compounding it, and they said it would be possible, but we have not done that. But significant pain reduction for the procedure by using topical lidocaine. Unfortunately, the lower percentage, like 2% gel that we have in a lot of our clinics, is great for speculum, great for preventing pain with the block and the tenaculum, but probably not enough to make a difference for uterine pain. So in summary, cervical biopsy, paracervical block, tenaculum placement, even low 2% gel. But if you're wanting it for intrauterine, probably higher level. And one little comment about the tenaculum, yes, they have studied cough. There's very little support for cough making a difference. Topical works, and the most effective in a comparative trial is injected 2 cc's of injected lidocaine. So the cervix is small. It's a small piece of tissue. When I see studies that say mean pain with dilation of 5 or 6 out of 10, which is absolutely routine, it just makes me realize this study is completely not useful to me, because we at CPO have routinely expected to get to no pain with dilation because we can. The cervix is really a small piece of tissue. And if we find that someone still has pain with dilation, it's easy to add more, wait a little bit longer. And as I said, I usually say, I'm checking. Please let me know if you feel any pain. Fundal uterine pain is more challenging. We can't really test for it. We don't know exactly how much is absorbed from the cervix up and higher. So people have looked at how we can get that information or get that medicine up into the fundus also. Intrauterine installation of local anesthetic has been studied and found to be particularly helpful for EMB, at least those are the studies. Lost IUD removal, less so for IUD, in a high percentage. I showed you the study for aspiration. And as I also said, mixing it with the distension media for hysteroscopy, not helpful. So for EMB, it's particularly helpful to know that if you instill into the uterus, it does not affect pathology. That's been studied. Some studies show it as effective as paracervical block, but those were 3 to 5 cc paracervical blocks. So I would take that with a grain of salt. And how do you, for intrauterine anesthesia, this is how we have done it at CPO. We actually did it for a couple of years on everybody, but having to have 2 separate setups was really challenging. Take an angiocath, take the needle out and attach it to your needle. And it's very slow infusion, 5 cc's of 2% in the uterus, and let it sit. Abner Korn does this routinely in his special procedures clinic after a block. And I think the combination of the two is a great idea. So what we moved to at CPO is intramyometrial injections. And that's mainly because I have the tools in my hand. I don't have to do 2 separate types of lidocaine setup, but we want to get the medicine into higher up in the uterus. I kind of thought I invented the going through the os, getting the internal os, but when I wrote the chapter for the textbook on abortion, I read the really old chapter. And the author also said, if someone has any pain with dilation, just put your needle through the os and give it at the internal os, and that usually takes care of it. So people have been figuring this out for a long time, that it doesn't always absorb all the way through the cervix, and the sensory nerves at the internal os sometimes need to be directly numbed. Yes, this has not been studied, but I also can't imagine anyone else in another study being like, oh, I can reach those nerves and I'd like to block them, but I won't do it because it hasn't actually been studied to put the block exactly there. But it is reasonable to wonder, well, could I hurt something by putting a long needle all the way into the uterus? And obviously, if you go through the back wall of the uterus, you could get bleeding that can cause an achy pain that you can't make better. It's not going to cause danger, but it could. So I would usually just go to the internal os unless I can see. And if we have an ultrasound there and I can see the needle going through the os into the posterior wall, or especially for anteverted, if you go over the tenaculum under the bladder, you can often get the entire uterus. That is an option. I don't like to say you need an ultrasound to do an effective block by any means, but if you have one, it does give you other options. And then if someone does have pain, stop. I had my own experience of someone, when I was an 8 out of 10 pain, like, what would you like me to do now? Like, note to self, let's not ask people when they're in 8 out of 10 pain what they'd like to do. Sorry, so making a plan ahead of time, or just we're the ones, we're the ones with the tools. So if they have pain, stop. And I can give more. I can wait longer and I can give more block if I'm using block, which I am for uterine procedures. And the more time for local to work, it's not clear that a longer time really makes a difference. But when someone is not responding to block and they're still having pain with dilation, I have asked probably a couple times a year if it's okay if we take out the speculum and give it 10 minutes. I have colleagues who do that routinely. I don't think that's needed, but it has been absolute magic. And the longest I've ever seen was someone who had misoprostol, needed to get up to have diarrhea. We took out the speculum, took 40 minutes before they were ready to start, and they feel nothing. So I know that lidocaine with vasopressin has a really long effect time, and there might be some people who need time. Now, if you haven't given enough to start with, no amount of time is going to make that better. So I would say adding more plus time should go together. So in summary, our standard block is not enough. Can we be a little bit more like other specialties and try to really minimize pain with the block, with buffer, injecting ahead of the small needle, and using topical before we do that? Using a larger dose, adding more if someone has any pain. We know we can go up past 30 mLs of 1% lidocaine, and waiting for it to work, especially if it's needed. And I don't sit on my hands and do a count or an automatic wait for any of these procedures automatically, but I do something to test very slowly. And then aiming for all the nerves we can, or at least more nerves than would be standard. We don't know that there's one way to do a block. Our goal is to get it everywhere. So if there's somewhere that they feel pain, I can add more in that area. So in closing, my overall recommendations would be to provide pain and procedure information before the visit. I just wrote something for a CPO that we're hoping to put on the website that will give people powered information about what the options are so they can think about it ahead of time. Normalizing pain control measures, not presenting it as a, well, these are all the things I can offer you, because that's a very big menu. But to make a recommendation and say, and some people with these priorities or different priorities might prefer this, or asking what their priorities are first. Always asking if there's something that they know, people know their bodies, and if they have had an experience that they know helps them with gyne procedures or gyne exams, or that really didn't work for them, it's extremely helpful to know that before. Prioritizing comfort at each step, going slow, even when we don't have time, just slowing down at that one moment and stopping for pain. I have to say, one of the most strong feedback for me to feel like this is really worthwhile is the people who have shifted from not doing block to doing block for procedures. This weekend, one very expert NP who puts in tons of IUDs was saying, the reason, I'm glad I finally switched, and what finally made it clear that it was the right thing to do was my patients who had told me that everything was just fine with their other IUDs, but then once they experienced it with a block, it was dramatically different. So I feel like there's really worth taking the time and thinking about it. And I feel like I have an argument for every population where people might say, well, I wouldn't do it in that population. But optimizing and testing and adding more, and using a lot of topical lidocaine or a lot of topical anesthetic, I found has been an enormous tool. So I hope I've given you some good tools, and we have a few minutes for questions.
Okay. I don't know if we have in-person questions. We have a couple of questions from Zoom. Excellent talk. Thank you, Karen. And then if anyone has questions here, we'll just repeat it so that people on Zoom can hear. Mika asked if you have any information on using TENS units for pain control. She had a question if we have it available to Mission Bay, and it sounds like from Melissa Rosenstein that we have plans to offer TENS units for labor while on the unit. So that's upcoming at Mission Bay, but I'm wondering if you have any thoughts.
Yeah, I use that as my example, how there's always more to learn and more to do, because I've known about TENS for a long time, yet we don't have it at CPO. And, I've thought about they're $40 on Amazon. You can buy one for yourself, or you can recommend them. And so there's good evidence for it. The time to set it up and to counsel people about it is the thing to think about. So for quick procedures, I think that's the barrier for IUDs, EMBs, especially. But it's for labor, I would say absolutely. There's hardly any downside. Yeah.
Patients sometimes complain about unexpected charges.
Yeah, I mean, the block for uterine aspiration is part of the global. And I also understand that for IUDs and EMBs, it is not an additional charge, although there might be some private insurance that pays for the medication. That's possible. For for instance, if you use an ultrasound for an IUD or an EMB, often I don't want patients to get a charge, so I won't, I'll put it in my notes, but I will not charge capture it or take a picture so they can't bill for it, because it's not adding time to my the experience, but that's okay to admit to. But the if you do need to actually use it, you need to use the modifier that says that it was a higher level or more difficult procedure, so that for charges, particularly for medications, I don't think it's that big of a deal. But I also think that could, if it ever is that someone is paying more for it, which it would be a small difference in the overall experience, it needs to be part of the discussion. Yeah, Caroline. Yes, the question was about misoprostol for pain, and I only had one slide on it, and I glossed over it really fast, so I'm not surprised. But there's a lot of data of misoprostol looking to see, because of course, if the pain is from dilation, you would assume, well, if we get the dilation there, then it will be less pain. And yes, it does decrease pain in some circumstances, but it also causes a lot of pain beforehand, causes side effects, causes more cramping afterwards. So all the guidelines that have come out looking at that data have not suggested using it routinely for any of those of the intrauterine procedures, but it doesn't mean that in a specific circumstance that it couldn't be worthwhile, and using it for other reasons, not pain, is obviously still recommended. Yeah. Yeah, the question is about moving your block from the easy to inject fornix into the stroma, and now that when that can be hard to do. And you know, I have even like a thumb injury, and I do really appreciate control injuries or control syringes, but I find that I don't have trouble doing it slowly. And there are sometimes where you'll hit a spot where you're like, nope, that's not going in, and you just move. And occasionally the density really is too much to overcome it. I do sometimes use two hands, but I find if it's, as long as you're going slowly and in the stroma, it's pretty rare that I hit a spot where I really can't inject.
Maybe we can take one more question from the chat. There is a question from Naz Hamafar. For LEAP in office with potential to be bloody, what do you recommend for local if Lido with epi is not as useful for pain relief?
Yeah, vasopressin. I mean, vasopressin 3, 4, 5 units. We use it for uterine aspiration routinely, and we use it for LEAP as well. Sorry, she asked, what do you recommend for bleeding control also and pain control for LEAP? Sorry, I didn't I don't need to repeat it for you. Sorry. And so I would say vasopressin. And I actually sat next to Matt Reeves, our former resident, who is head of NAF for many years, who did the studies when we had a vasopressin shortage. And this weekend, I was asking him, like, is there any utility for epi in cervical block? And he's like, no. He's like, I did the studies. It just doesn't even work. And it's way too much vasopressin. And I mean, way too much vasoconstrictor. So I think we have a pretty clear, we have a good tool, the vasopressin. It is no longer $122 a vial. So it is less expensive now. And mixing that with a TB syringe, because the dose is, it's very important to not overdose.
Thank you, Karen.
Yeah. Thank you.